I'm Ira Kirschenbaum. I'm the editor of the Journal of the Orthopedic Experience Innovation. Tonight we have an amazing faculty and audience. Tonight, this this topic session will be moderated by Anand Murthi, and who needs no further introduction. And I will leave the rest up to Anand to introduce the faculty, have them introduce themselves, and I will only interrupt if I ever learn something about shoulder surgery. So,
excellent. All right, I'm going to share my slides here. Ira, how am I doing? Can we see everything?
see everything's perfect.
Welcome, everybody. We set a new record today, I think, right, Ira, with the Joe webinar. We've done a bunch of these. This is really the best way to communicate with our colleagues and ask questions in a live forum. We have a outstanding class of faculty today with myself. I'm Anand Murthi from MedStar Baltimore. I'll be moderating and herding all these guys along. We've got Greg Felice from HSS, Kevin Bonner from Jordan Young in Virginia Beach, my old partner Lou Schon from Mercy Medical Center, and Mark Morrey from Mayo. What we're going to do, we'll talk a little bit about active braid and what it's about, and then we're going to have some fun cases, help moderate, and I'll be picking on some colleagues and plants that we've placed in the crowd to answer our questions. So we've got a little bit of time. And also, please, I think attendees can raise their hand, correct, Lou, to get some questions in at the end?
The best is to put it into the chat, and you can look there, or I will tell you there's some stuff in the chat.
Awesome. So a little bit of background for those who don't know about this relatively new product, Active Braid. It's the first of its kind biointegrative collagen Co-Braid. It's collagen and ultra-high molecular weight polyethylene, and it can really be used in all parts of the body. And we'll go through some of our cases. And it's when people ask about whether during its development, whether its strength is compromised or less abrasive, it is not. Really easy to use. It's 50% collagen by weight. Its strength is maintained. It's got a proprietary braiding pattern. I'll ask some of our developers to comment on that. It's as strong as you can see in these tables. Strength is not an issue. And I've been using it a lot, and I'll show you some of the examples that I've used. And, you know, when I make it simple for everyone, you're essentially bringing these stem cells, blood, where you want the healing to occur, and it stays there. And it stays there, and, you know, essentially we have a suture or a tape that's almost like a graft and a wick. These are our fancy slides, which they ask us to show about cell proliferation and how it's held there at the site, and really in an aligned manner as well. So it adds collagen without compromise, significantly more cell attachment and proliferation. No reactions. I'll ask Kevin to talk about that in a little while. Easy to use, easy to tie. And really, we're going to show tonight available for a lot of different applications. So, Kevin, before we start, can you talk a little bit about the development of this new suture and tape?
Sure, Anand. So basically, you know, several years ago, you know, we had our focus on different patches, and I think patches certainly have a role to augment healing. But then our mind started going off and wandering and saying, you know, why can't we develop a collagen suture? And there are a lot of hurdles to doing that in terms of maintaining the integrity of the strength. And could we create a collagen suture that is just as strong as the currently available high-strength sutures in the market? And there were several challenges to go through. You know, myself, Greg DiFelice is on, and Nick Scaglione, we sort of teamed up and with the team at Embody and now Zimmer Biomet. And basically, we were able to create this Active Braid product, which is a combination of collagen and then high molecular weight polyethylene. And when people say, well, you know, I don't like high molecular weight polyethylene, doesn't that, you know, they sort of assimilate that with polyethylene wear and knee replacements and things like that. But the fact is that all the other high strength sutures are made of the same thing. The difference is that the the engineers were able to create this braiding where the braiding patterns are a little bit different. The fibrils are smaller, and we're able to create this collagen suture, which is slightly over 50% collagen with high molecular weight polyethylene. So as you said, the strength is maintained. It's just as strong as the equivalent fiber wire, but it's over 50% collagen. And that's where the biology comes in. We wanted to create a suture, let's face it, again, there's a need for patches, but patches can be more expensive. They can be sometimes difficult to put in. So the goal was to be able to put collagen into every repair we do. And that's sort of, I think, what we achieved with Active Braid is that no matter what you do, foot and ankle, knee, shoulder, hip, you can actually augment every repair with collagen.
Awesome.
And that was sort of that's what led to development of Active Braid. And here's just a case. And I think the nice thing is that you don't have to interrupt your workflow. So here's a typical rotator cuff that we're doing basically a bridged double row repair, and we're using Active Braid. And when you look at Active Braid, it's sort of, we've been calling it the quicker picker upper. If you use it, you can actually, not only does it absorb things like blood, PRP, et cetera, but we're actually doing various studies looking at the absorption of antibiotics, things like doxycycline, vancomycin, things like that. And we can talk about that later in the program, but we're pretty excited about this.
So, I've used it too. What do you think about its handling properties? I think it feels to me it's almost like a one-way. It really slides down easily, and doesn't unravel, which some of the competitors have issues with, kind of being too slippery.
Yeah, no, I agree. It's from a tying standpoint, the knot stacks are actually slightly smaller. And when it comes to cutting, we've all cut our hands with fiber wire, and we've all seen fiber wire cut through tendon and soft tissue. So it actually cuts through less than the competitor's product. So that's another benefit, is that it actually has less cutting through soft tissue as well.
So obviously you and I and other people on this call and in the audience are looking for the holy grail for cuff repair. And, if we can use this, doesn't change your workflow, delivery is simple, we're going to get it on anchors eventually as well too. I think it really adds to our ability to repair the cuff and kind of bring augmentation and blood and stem cells typically to that area. So thanks, Kevin. I just added this today. I've done about 7 or 8 cases now of AC separation, both acute and more of an issue chronic, where those of us do a lot of AC joints know has been no great answer to the AC joint reconstruction. There's 5,000 types of devices and techniques. So, I wanted to get away from grafts, which can cause lysis, drilling holes, which can cause fracture, going to really small tunnels or around the clavicle. And I had a case where I didn't want to use any graft. It was a revision, a long story, but I just used the Active Braid, no graft on a chronic separation, and did a typical around the clavicle subcoracoid and drilled a couple of tiny 1 millimeter holes in the end. And now that I've done 6 or 7 days, I think they're developing this robust reaction and healing response where I have no graft, cost savings on graft, as well as the lack of revision or even any change in the fixation, and the reduction has been great. So just another option where we're going to follow these patients as well to show that we can use this Active Braid in a case where previously we had no great answer for. So I'm pretty happy about that. So subscapularis repair, those of us who do a lot of arthroplasty, I've been using now for tenotomies, for LTOs, and both reverse and anatomic. This is Active Braid, just tissue to tissue repair. I've actually put tapestry on top as well. I think we really don't want to have any failures of the subscapularis. So I think that's really a great option as well. I don't know if Paul's on there. Sethi, can you respond? Can you talk? Or are you driving?
I can talk, actually.
What do you think about augmenting subscap with grafts, biceps, Active Braid? Do we need it?
look, clearly the subscapularis failure is still a mode of failure and probably under-recognized because some people get away with it. So yes, I do think we need it. And I think if we can do it in an economical way with simple suture, it's a good idea. I was a little skeptical. I've done a couple pec repairs with this now. And honestly, you guys are telling the truth. I have no conflict with this product, but it handles really well, slides through really well, and it wicks up the tissue. So it's a nice biological augment. It's satisfying.
Tell me how you did a pec with Active Braid. Did you put it onto an anchor or just side to side, or how would
So, now conflicted, I did load it into a metallic button, and I did tension slide technique with it. And I just substituted standard suture material for an augmented wicking material, which, as Kevin Bonner said, and I'm jealous, Kevin, you developed this because it's a good idea. But it's
Look at Kevin smiling. You see him smile when you said that?
So Paul, you've developed lots of great things too. So I'm jealous.
you don't need to pump me up,
the
man.
bro club. Pat each other
Mutual
on the back.
love. Mutual love. But nonetheless, look, it was very rewarding in terms of its handling characteristics, and very rewarding to see it actually absorb the blood product, because that's really, where you have that aha moment.
Yeah, it really just makes sense. You're bringing blood and everything that comes with blood and the growth factors to a zone of repair that you want to stay there, and something that's not abrasive. And Kevin, we're going to move on to the inferior extremity down to the knee, and another example of where we can use this in a really cool place. Talk to us about meniscal repair and ramp repair.
Yeah, so I think the next few slides, just different, versions of doing different types of meniscus repair. So here we are, scope is in the back of the knee, looking posterior medial. There's a cannula posterior medial, and basically using the Active Braid to perform a ramp repair. So just one of the ways you can use it, you can pass it. It's easy to pass and it's easy to tie. So, again, you're not changing your workflow whatsoever, which is nice.
Do you have any issues? People are the look of the suture. Is it going to be abrasive, or have you had
it's funny when we first started looking at it, we had the feel, is this going to be more abrasive? And the bottom line is that it's really not. And if you look at the cutting characteristics relative to competitive products, it actually cuts through less. So, that was nice to see. And here's another case. This is just a root repair that we did, same thing. And then I think the next slide is going on to another more standard. So this was sort of a meniscus tear at risk. This is a displaced bucket handle lateral meniscus that was out for several months, actually. And it was one of those ones that I wasn't sure if we could fix it, but the person was relatively young. And so I did a hybrid type repair. I did an inside out posterior repair. So you can see vertical mattress stitches posteriorly. And then for the body and anterior horn, we're going to actually use the Active Braid to perform an outside in repair. So this I thought was a tear at risk. And I thought it was just another nice utilization of Active Braid. And ultimately, this is going to be on meniscus repair devices, as well as inside out needles for those of you who still do inside out repairs, which, just like in this case, I still do them. I did a meniscus transplant today where I used them. So it's going to be very nice when Active Braid is on all inside devices and inside out needles. But here's just an example of a tough case, a lateral meniscus at risk of failure because it was displaced for several months, that I was able to reduce and repair with a hybrid technique. But part of the hybrid repair technique was utilizing these Active Braid sutures, both on the femoral side as well as the tibial side.
Wow, that's pretty cool. Greg looks jealous. DiFelice looks a little jealous of your technique. All right, quad repair. So now we're going to get into these cases where, all parts of the body that need soft tissue reinforcement, especially chronic. Tell us what you're doing there. What was that little soak?
That little soak. So we're actually looking at this in the lab right now. So soaking that in vancomycin. So I think if you have any cases that you're sort of concerned about infection, and not that we got a lot of quad, rupture infections, but quite frankly, those people who are doing knee replacements and things like that, people are using it more and more for their capsular closures. So I think any case that you're at risk of infection, it's nice. Again, it's sort of like the quicker picker-upper. It really absorbs antibiotics, and we're doing a study on it. And I think what's going to be interesting is different types of antibiotics. Doxycycline, for instance, for rotator cuff repair. I think that's going to be very intriguing to potentially help with our rotator cuff repairs for multiple biologic reasons. So this is just a quad repair case, small knot stack. It doesn't change your workflow, soaking it in vancomycin, and it's just another utility to using ActiveBraid.
Off-label, of course, at the current time.
Yes.
We have to say that the ZB administration is going to twitch unless I mention that that's off-label. But I love it. I love it. I think especially in arthroplasty, we're repairing our subscaps with ActiveBraid and loading them up with antibiotics has got great potential too. So here's another patella tendon as well. So that's pretty cool. So this is just an environment. I like this slide because it's hard to tell when Kevin and during the scopes how this wicks up the blood, and you can see kind of in real time, how this ActiveBraid absorbs all this blood and kind of holds it in that area that you want to have repaired. It supports this tissue formation, and it has really cool alignment compared to collagen-coated fiber wire with increased ingrowth. And so that's where we're thinking about where to use ActiveBraid. So these places where we want ingrowth, elbow, Tommy John, things like that, ACL, Greg's going to show a case here where we really get increased growth in that alignment that we want it to be in. So Greg, you're up next. Thanks, Kevin. We're going to talk a little bit about more sports-related knee issues. Kevin, all right, Greg, you on? Awesome.
Sure. Can you hear me?
Yep, sounds good. Take us through this video. What's happening?
Great stuff. Kevin, I was fortunate enough Kevin was my chief resident, and Kevin was coming at this angle a little more in the shoulder, and he knew that I was doing a lot of work on ACL repair, and we both agreed that it's a great idea that you can have the sutures that can partially go away, right? Forever, I've been trying to let everybody know that we can do ACL primary repair, and actually it works. And hopefully some of you have tried it and have jumped on board. But wouldn't it be great if you can have the sutures go away? I mean, in reality, my ACL repair technique, I call it the rotator cuff repair of the knee. And so Embody came to me and said, hey, we've got this cool technology. Do you have any ideas how we can use it further? And immediately I was on the bandwagon to try and develop sutures so that we can repair the ligaments around the knee when they're in the appropriate tear pattern. So you see here, I'm weaving the number 2 round the number 2 round ActiveBraids. Excuse me, I almost said that. That's not right. In the past, I've used the predicate sutures, but here, and since last September, I have used ActiveBraid for every single repair, soft tissue repair in the body, from the shoulder to the hip to the knee to the ankle, and without any issues whatsoever. It handles well, it soaks up the blood, and this is a great example of a nice ACL repair to augment the healing.
Are you using it for just standard ACL repair with graft also, with BTB or hamstrings also?
Yeah, I use the 2.5 tape to do a suture augmentation for any time I'm using a graft. I use the number 2 rounds to stitch the bundles, and then I suture augment that with a 2.5 tape if I'm doing a repair. And since this January, I've actually started to do the bear implant. And what I do is I've modified the technique. So I do my repair technique, and I put the ActiveBraid tape through the bear implant and then pop it into the knee. And I've done about 25 of those, mostly for mid-substance tears, to be quite honest with you. My feeling is, and I think my research has shown, that proximal tears don't really need the bear implant. But in my hands, the mid-substance tears that are kind of torn up, that's where the bear works well. And it works hand in glove with the collagen sutures. And then to add any extra collagen augmentation that you might get from either the Bear or any of the patches or anything like that that you might need. So here you see me doing an MCL repair, kind of a mini approach MCL repair. I'm a big believer that's quite a number of MCLs would do better off if we simply repaired them than put them in a brace and waited. And my group has published quite a bit on that. And here you can see it's a great use for both the sutures to repair the proximal tear and also the tape to reinforce it. So super all around the knee, just great applications for this technology.
That's great. Some more your meniscal work here, which is awesome as well. Are you using it as well for meniscus, as Kevin was showing a little bit earlier?
Sometimes for the ramp tears and things like that. What they're showing right here is actually an augment where when the ligament remnant isn't long enough to actually reach the wall and go for a repair, what I'll do is still save the ligament remnant and put the active braid sutures into the remnant to pull it up tight and then swing a graft in right through the remnant. So it's a remnant tensioning augment. So, and here you can see that the difference between the active braid, which is red and soaked up with all the blood, and some of the other sutures that are coming from the tightrope mechanism that don't have the collagen in the sutures. So it really is just a great biologic way to get biology into whatever it is that you're doing without breaking the bank.
So you've done all these ligament repairs and meniscus. Any issues with, when people talk about new sutures, grafts, patches, have there been any reactions that you know of? Any stiffness issues? Anything you'd like to comment on about that?
No, to be quite honest with you, none whatsoever. And I think, in the beginning, they had a bit of a manufacturing logger jam, where they couldn't get it out fast enough. And in the beginning, I think I probably used the most of this because I started last September. And so I've been using it for a full 13 months. And I went all in. I completely stopped using the others, the fiber wires and fiber tapes, and replaced that 100% with active braid. And I have a trauma heavy sports practice. So literally every tendon in the body that's torn, I have fixed with active braid, rotator cuffs, pecs, biceps, triceps, quads, patellas, hamstrings. I even did a quad repair, proximal quad repair, rectus off the hip the other day. So
you guys don't know, Greg really likes active braid.
Yeah, good stuff.
He puts it on his spaghetti. He puts it on steak a little bit. He shaves it up a little bit. Occasionally. All right, that's great.
Anyways, good stuff.
These are awesome cases. Is Nirav Amin, are you available to speak? Let's see if he can pull up while we're getting this next one ready.
I am Dr. Murthi. How are you?
How are you? Oh, Dr. Murthi, so formal. So talk to me about when you would use something like these devices. I know you're really forward thinking, and tell me about that. What are your thoughts?
Yeah, Anand, I think the first question is, I think as Kevin alluded to nicely earlier, is there a concern of a reaction, especially when you first put it in your hands, right? And it gets a little moist or wet. I call them like kind of the little fibrils kind of start to separate. And the first concern I had is the strength of the suture going to stay at time zero what it is. When you look at the biomechanical studies that they've done internally, it shows that it's 85% is 6 months out. And your hope would be, if that is the case and you're not having a reaction, 50% is turning to collagen, at that point, you hope your tendon is healed to that level, right? Because if the tendon's not healed at 6 months, I'm not sure what you can do at that point, right? At some point, the construct is going to fail biomechanically. I will share with you very briefly. I've done it, as the audience has alluded to. My number one is actually in the labrum for instability cases, on my revision instability cases.
Really?
When I'm doing a remplissage, I like putting it in the back. Or when I'm doing a nautilus repair on the labrum in the front, I like the idea of the collagen giving me an added buffer of more soft tissue versus just tissue on that side. One other indication I've used a lot, and I mean, DiFelice really talked about, I think the ACL is a brilliant a biologic augment, and that, sorry, a biologic suture. And lastly, I've actually done it on from the total knee side. If I'm doing a revision extensor mechanism allograft, I'll actually use it to crack out through my suture so I get collagen at the footprint between the bone tendon interface. So I think it's got broad applications. I think in my head, wherever there's a number 2 fiber wire, this replaces it. And lastly, just cost-wise, it's very reasonable, right? We're not talking about a cost of, let's say, $100 versus $500. The cost delta is not significant to where it becomes a non-starter.
Yeah. I think you hit it on the head, especially in the cuff, like Kevin showed earlier, we may be using this instead of some patches, to be determined, but in certain cases, especially revisions or cuffs at risk, low Rohe score, patients that are, poor hosts that don't really have a blood supply, smokers, things like that are where I'm probably going to lean towards using it in the cuff as well. And I think the easiest thing, like everyone's shown here, is the ease of use, Kevin and Greg are showing how easy, and you're not changing your operations and how you do these procedures. And I think that's kind of one of the bigger benefits of it as well. So that's pretty awesome. I have not thought about it in the labrum. Now I'm intrigued. So are you passing it through a push-in type of anchor? Is that what you preload, or pass it through the tissue first, the labrum first?
So I pass it through the labrum first, and then I do a luggage tag and I bring it up. Typically, if it's, let's say, a tear from 6 o'clock up to, let's say, 3 o'clock, I may put a curved anchor and tie my most inferior portion for a big capsular shift. And then as I work my way up the wall, I'll probably put into a knotless anchor. So then I'll just use like a lasso with a PDS and then pass it through. And it works really well. It's really efficient. It's the 1.5 tape that I use in that setting.
Oh, that's awesome. Dr.
One last thing I'll tell you really quickly, right, is when you just hit on the head, especially with Medicare, right, and the ASC cost being a real phenomenon, this can really replace, if you're concerned with the biologic component and your cost construct is a worrisome part, this can supplement that without needing to worry about cost at an ASC.
That's awesome. Hafiz Kassam, talk to me about if you would use this in reverse for fracture. We really need to get the tuberosity to heal. Are you on? Are you online?
Yeah, no, I'm on. Yeah, no, I was. Yeah, I mean, I think it's a great indication. I mean, that's kind of what
hold on. So Dr. Kassam is a superstar arthroplasty shoulder and elbow surgeon out in Newport Beach, OC, where I want to live, but he won't let me come. All right, keep going, Hafiz.
First off, I'm protecting my turf. That's why I'm not allowed to come. But then second, so I think most important. Yes, I mean, I started transitioning for subscap repair, and then it just happened to be the same day I was doing arthroplasty, like for reverse fractures, and it makes a lot of sense because I think the idea is you're really trying to get tuberosities to heal for it to work. So I've transitioned all of my reverse arthroplasty, all of my reverse for fracture for the tuberosity repairs.
Yeah.
And it's great because it's system agnostic, right? So regardless of what system you want to use for fracture, you have the ability to go transosseous through the stem, around the stem. The lengths aren't any different. And I think, we talk about bone grafting the tuberosities with whatever's left of head. I mean, that's all pretty variable for anyone who does it with any high frequency. So I think I felt pretty good about it. I've been doing it for about 2 months, and my x-rays so far have been pretty, reasonable. I've had no differences, and I think it makes a lot of sense in terms of getting a more robust repair, whether that's true healing or inflammatory response. Regardless, the tuberosities are sticking. So I think that's really what you're trying to get going.
It also has great handling for fractures too. When you're cinching, you want that tension. I think that's one of the key things that's nice about kind of the broader tapes, these broader active braid tapes. So
yeah, and I think there's a bit of a learning curve when you're tying it open by hand, because you'll see some of the collagen fibrils kind of come on. You just have to remember that it's fine. Like it doesn't matter. It's okay. It's just there's like the first time you do it, it just looks a little bit different. But once you realize what it is, it makes you feel better, right? Because it's actually collagen that's kind of getting into the wound. Yeah.
Blood. Thanks, Hafiz, for joining us. Checks in the mail. All right. From ZB, not from me. All right. So next up, awesome, world famous Lou Schon, foot and ankle specialist. Used to be my partner, left me hanging a little while ago.
Your partner.
Lou is going to take us through his wonderful journey with Active Braid, and we're going to start here with the perineal repair.
Yeah, first, I'm going to go a little bit backwards. I was on BME faculty at Hopkins for a long time and still am, but we came up with a stem cell suture. And 2008, 2009, we did a lot of research on a mesh and a suture, and we didn't have the collagen. We had a different material, but we basically proved out with rats the superior histology with the suture with stem cells in it versus just suture alone, which was lousy, and suture with an injection, which was better. But suture with stem cells, it looked like it was normal. And, of course, it's rats. Rats heal, and every rat in Baltimore and New York come to me. They love me because I'm the rat doctor. But in all seriousness, I've been using bone marrow BioQ, the BMAC, the bone marrow aspirate from the pelvis, get 60 cc's concentrated and injected in. I've been doing that since 2004, but I didn't have something to hold it. Now I've got something to hold it, and I've been really excited. This is a perineal tendon, and you can see the tear in the perineal. And I'm taking the suture, I'm soaking it in my BMAC. So I harvest the 60, spin it for 15. We then put the suture in it, and it will soak it up, just like you saw in Kevin's little video. And let's go to the next one. Then you take that and you can suture. Now, this is a suture that I don't want to have this on the surface. We don't have a lot of space here, and I want to keep my knots buried inside. I want to keep my suture inside as possible. But it's basically, and I don't use a tourniquet, by the way. I don't know if you figured that out. But basically, I keep my suture inside. I run it up and down, bury my knots inside, flip the tendon around, and it handles beautifully. And it looks great. But more than that, I know I've given them the stem cells right where they need it, right at the tear. And so it's been super positive. This is an Achilles tendon.
What size suture do you use down low here in these smaller tendons? Is that 2.0 or is that the number 2?
So if I'm in a more robust tendon, I'll use, and I need more mechanic, I'll do number 2. And if it's something a little bit less mechanically critical, I use the 2.0.
That's
so
really
so
cool.
let's see the Achilles. So this is just a shredded tendon. Shredded. And you can see I put my Active Braid through all the different components. I like to tell people, when you have a tendon like this, you treat it like a fracture. This piece goes to here. This is the void that you pull the shard over here to there, and you reduce it and you get the tension that way. So here I've kind of lined all my pieces up, starting to pull it together. Handles just the same as any suture, and probably a little better because it doesn't, it bites down. You feel better when you're tying this knot. It kind of locks it down. It doesn't stack high, and I'm able to bury it. And here you can see my repair. That's the same tendon. This is not TV magic, folks. This is real stuff.
No Photoshop here. No Photoshop.
And no tourniquet. And you can see it's not bleeding, but same thing. Just then we had here I'm tying my knots, making sure your knots are on the internal aspect of it or inside the tendon. You don't want to have it rubbing on the end. But if you do, it's not as bad as the other material, which will abrade your incision. So I always make my incision, by the way, 1 centimeter anterior and 1 centimeter medial to the tendon. So I've got a 1 centimeter cuff going down to the tendon before I get to the tendon. I don't make it directly over the tendon. It's that 1 centimeter anterior, go down, and then cut back to the tendon. Now here I'm laying tapestry on it, and this is less of an augment mechanically, but a fantastic augment biologically. And here you can see I've wrapped it around, and I haven't soaked it because you'll see when I soak it, it looks pretty funky. And here it looks soaked in with the bone marrow. I drip it on it. It soaks up right away. It's very very
Tapestry dumpling. That's what it is.
beautiful. And I mean, this looks great. It felt great. Again, no workflow change. But if you're doing the tapestry, I don't usually do a wrap. I don't like the other wraps. I wouldn't use the other wraps. This wrap makes sense to me. So call me,
Yeah, it prevents scarring. Do you think that wrap is helpful for scarring?
I don't know. I do know it's going to give me a bit more of a biologic enhanced repair. Now we did this with shooting the into the tendon after repair after everything was closed, but we didn't have the suture to hold it, and we had faster times to recovery, fewer ruptures, less atrophy. But here you can see we've taken the bone marrow from the pelvis. I use the contralateral pelvis because I do this supine, not prone. So I have the foot externally rotated. This left foot is on the table. The right pelvis is up. I go to the pelvis, take my BMAC 4 centimeters proximal to the ASIS. I do multiple trajectories, drawing out 5 ml aliquots at a time. We spin it down, and then we take that and we soak the suture and we soak the tapestry, but the tapestry is put on first just so that it has a little easier handling characteristics. If it's all wet, it may not be as good to work with. The suture is not a problem with that, but then we'll put that on the tapestry and then do our typical layered closure. So I'm in love with this. I'm excited about the future. This is, my dream from 2008 has finally come to fruition, and look forward to seeing great results. Thanks for having me.
Hey, Lou,
We appreciate
question
it.
for you. Hey, what do you think about, can you pull the BMAC out of the proximal tibia? You think it'd be as effective or no?
Yeah, so we looked at that. You get a lower density of cells, but you can get a high volume. If you go, for example, some people are going from the calcaneus, and you're only going to get 30 cc's. That's the volume of the calcaneus. So your calcaneus has a higher density, but you have a lower volume. Your proximal tibia, you could go in there. You don't get the same density of cells as you do from the pelvis, but it's good. You're going to get a little bit more fat, but it is good. And definitely, I would recommend that over nothing any day.
That's awesome.
Great.
And Lou, it's incredible, when we first were in practice together, how much things have changed with biologics, and it's incredible to think what's going to happen in the next 10 years. So thanks for your thoughts and appreciate your time as always.
Well, this is a real breakthrough. So congratulations to the developers. And I'm looking forward to really getting people better, faster, and more completely with this product.
That's great. Awesome. Thank you. So we're gonna roll into my second favorite joint, from Dr. Morrey, who's gonna take us through some pretty cool cases. I got to look at these a little earlier today. So Mark, first tell us about your experience with Active Braid, and then we'll go through these fun cases.
Sure. It's amazing. I've had a very similar experience to Lou. I did a master's at Oxford with Andy Carr in 2012, and it was all on biologic reactions to different suture materials and how the body responds. And so when I'm evaluating a new suture material, that's kind of where my mind immediately goes. And the very first experience I had with Active Braid, I used it, and I'll show a case a little later, where I was tying the suture and I saw sort of the bristle brush happening with the suture, where some of the collagen fibrils kind of spring off of it, and I was like, uh-oh, I'm not sure about this. So I actually abandoned it for a little while, and then I came back to using it again when I saw the results, and I'll show a case where I had to go back. Unfortunately, it's not only going to be roses for me because I deal with the Hellbow, but the Hellbow is my love.
I've never heard that, Mark, but I will now use it.
Yeah, feel free, feel free. But this is a case, really unfortunate, young patient. He's 40 years old and he has a completely destroyed joint. He's completely unstable because he's lost some bone. And so he's indicated for an interposition arthroplasty, because I really don't like using total elbow arthroplasty in a patient that young. But it is also tricky to get the exposure, particularly when they're very, very stiff. And because the main failure mechanism is instability, you really need to do something to augment the ligaments when you're done. I mean, if you look at any study on elbow interposition arthroplasty, they all fail with instability. And so this is you can see a view from the back on the left, and then on the right, the ligament augmentation. So I used the Achilles, and then I used, in this case, a juggernaut suture anchor down at the on the lateral side at the crista supinatoris, and then ran that back to the proximal part, and then I augment that
Achilles
with
allograft on the humerus.
yeah, Achilles
This is
allograft.
for our non-elbow people.
Yeah. I should back
I
up.
don't even know what they're looking at, Mark. That looks like a chicken leg.
Yeah. Okay, very fair. Fair. So what you've got in the back is the triceps is actually, that's a triceps tenotomy approach, so that we can take the ligaments down from the ulna, because we found that has a much more stable construct. And again, it's all about instability. So you'll see a couple different things. So the graft is covering the end of the humerus now. The joint has been basically resurfaced with that. And I won't go into all the details. And then we have
here, olecranon here.
Yep, olecranon there, and then you see a tiny little suture. This is what he looked like beforehand, so you can see the amount of slop in his elbow, so to speak. So we've got to tighten that up with ligament reconstructions. And then at the end of the case, you need to fix the triceps. And I've been using this for these triceps repairs and this approach for total elbow arthroplasty, and also for interposition arthroplasty. And it's a triceps tenotomy, where then you repair the deep head, and then the long and lateral heads, or the superficial portion, independently of one another. And so I've laid a tapestry patch between those two repairs. And what you'll see next is so very similar to Lou, and you can play that little video. We use a rack and hitch, or I think there's this one's a video. Yeah, there you go. A rack and hitch, or a niece knot. And you'll see even with the elbow inflection, the knot holding security. So this has exceptional loop holding security. As soon as you get that thing down, just watch the two ends of the tendon come together, and the knot is not slipping at all. And it just holds it there. So you can reduce things, you can sneak up on it, you can tweak it a little bit. And this knot, of course, is under the triceps as well. And I really, really like that. So here's, you see the final sort of construct with the two rack and hitches, or niece loops, on either side of the triceps, and how it comes together. And that's with the elbow in 90 degrees. And I found that I can move patients right away with this repair. I do not need to lay off. And with elbow replacements or this type of thing, it really, you really need to be able to see to put the implants in the right spot. I mean, we've known that the failures happen when you can't put them in the right spot. And this is a case that I debated on whether or not to show, but I'm going to air my dirty laundry a little bit here.
Let's do it.
This is a patient who we repaired with that same exact exposure. So it was a diamond pop-up, we call it. There's a transverse tenotomy of the triceps. And at 4 months, her repair did not fail, her bone failed. So she had an eccentric load and she popped off her bone. So this owes to the strength of the repair. Now on the image to the right, you can see I've placed some niece knots, or rip stops with just vicryl suture across where that bone is. But the actual suture itself is just disappeared. It's just the tendon. So you go back in and you try to dissect that suture out, and it is just interwoven with the patient's native tendon. And when we did our work at Oxford, it was all about aligning the cells. It was all about getting fibroblasts to migrate into the tissue. And you saw those very sexy slides, Anand, earlier, with the fibroblasts migrating in there. And that's really the key, I think. And as the collagen disappears, that's where the strength of the repair goes. And at 9 months, if all the collagen's gone, the scaffold of the new cellular structure is there. And you can, the proof is in the pudding. You can see that grossly, and you can see it, under the microscope as well. And go on to the next one, Anand. So that was the repair. And then I've also been using it for subscap repair. Same kind of thing. I use a tenotomy.
What'd you say?
Keep going, Mark. Someone's got
All
their
right.
It's in LA though.
Okay.
Yeah, this is the last game in New York.
Talking World Series. What's the score? But anyway, so I've been using it for.
Please mute if you're not speaking. Please mute. Sorry, Mark.
That's okay. I've been using it for subscap repair as well, and again for the same reasons. It's a tenotomy, and you can get the loop holding security right away, and then not holding security just by tying some half hitches over the top. And it's been super effective in my practice for virtually every soft tissue repair, whether it's a medial collateral ligament in the elbow, a lateral collateral ligament in the elbow, triceps repair, biceps repair. I've been using this to really help augment and bring biology. And the beautiful thing, it's the patient's biology. So
Awesome.
I've been exceptional.
I had an elbow where I had to do a total elbow, and someone had an olecranon non-union.
Yes.
So we repaired the bone with the active braid, and it just like healed across it. It was incredible.
I did that exact case yesterday.
Yeah.
And I actually have another one tomorrow.
Yeah.
So patients, they're referred from everywhere, and it's like, what do you do with this? And it is an exceptionally strong construct.
Awesome.
I had to go back on one of my bear repairs to take a little cyclops lesion out. And typically if I ever go back in on an ACL repair, I'll see the fiber tape that I use for the internal brace. And many times it's not incorporated. It's just sitting there. There's nothing grown into it or onto it or anything. It's just sitting there. And, sometimes it's ripped in half and sometimes it's a problem. And we just published a paper, kind of pointing out that, there's this looming burden of non-absorbable suture out there in these joints that's going to come back to bother us at some times, which is why I love the fact that half of this goes away. And the one time I got to look at it, the active braid was completely encased in scar tissue, and it was grown in, and it was completely, just basically taken over by the body. So, I mean, I know it's an N of 1, but it was pretty impressive how much this stuff had grown in, and that's encouraging, I think, for the long run.
Well, it's super attractive.
I just wanted to say one thing is that I actually think it's better than scarring. It's more organized than that. So I think that's a big positive too. So someone had a comment?
Yeah, it's the fibers are aligned. So it actually, really helps with that. But when you're dealing with as many elbow disasters, you really don't want material to be hanging around. You want tissue, because if you have to go in, and deal with an infection, that's the last thing that I want to be dealing with. So, for me to support a braided suture is kind of counterculture. But I really like the fact that it disappears and incorporates itself so well.
I was hoping Don Buford, if he's still on, could comment on what he thinks about biologics and how this potentially could affect or help his practice. Don, are you still on? Going once, going twice. All right, we've got some questions before we finish up. For Kevin, do you think the collagen is absorbing the antibiotics, or is it the polyethylene suture material? What do you think, Kevin? Oh, Kevin, you're muted.
Collagen.
It's the collagen. Basically, when we compared versus competitive products, which were just high molecular weight polyethylene, high strength suture, it was dramatically higher than the alternatives. So it's the collagen.
Awesome. We have, are there any other questions? Anyone in the chat, please send your questions. I think we've gone through most of them in the talk. Absorption, collagen, adverse reactions. So I'm just going to finish off in our last couple minutes. If everyone on the panel could kind of give their thoughts on what the future of active braid is going to be, we'll give you a couple seconds each. Let's start with Kevin, one of the developers. Very passionate, not as passionate as Greg, but very passionate.
So I think that it's very interesting in terms of, I think we're going to be probably using more for rotator cuffs. Let's just start with that. More all suture anchors for our medial rows and utilizing this instead of patches going forward. I think from a workflow standpoint, and as everybody's already mentioned, I'm a part owner of an ASC, and I think from a cost standpoint, this is much more reasonable to use on a daily basis relative to patches. So I think it's going to be very intriguing going forward for using it for rotator cuffs. And then to that point, there's a lot of good research being done regarding the use of, for instance, doxycycline, looking at rotator cuff healing. So I think that not only will be beneficial to help with infection, preventing infection throughout all these different procedures. I was looking at Mark's, elbow, and say, one great utility is soaking it in antibiotics to prevent infection, because, if we can, improve our infection rates with all these cases, then we'll be helping a lot of people. But I think with doxycycline in the rotator cuff specifically, I think that's going to be very interesting in terms of augmenting our healing. And I think this is a great substrate to use for various different antibiotics, as well as PRP, blood, BMAC, everything else like everybody's commented on. So I think it is very, very exciting. And I think it's exciting in that it's not going to break the bank. And I think that most ASCs would find this completely reasonable, and it's not going to change our workflow, which is probably the nicest part.
I'm going to switch gears.
Don Buford just came on.
Oh, there he is. Don.
Sorry, I'm bouncing between webinars, so I'm back.
How dare you leave our webinar? So talk to me about, where do you think this will be in your practice, biologics, a biologic suture material?
No, I think this is fantastic, and congrats to Kevin and everyone else involved in this, because, those of you that remember way back, the first concept was let's just have an absorbable suture with Pantacryl, and we all remember the problems we had with Pantacryl going away. Now we have something that actually is a collagen-based, scaffold, which is what we need, especially when we're using other orthobiologics. All the results are better basically in any application if there's a scaffold. And so this is a perfect place to use something like this. I think this is going to be a real game changer. And I don't say that lightly,
Don, you're injecting BMAC a lot. How will you use this in addition? Would you soak the suture or just close everything up and inject?
Yeah, so that's a great question, Lou. So BMAC, based on what I've seen and what's been showing up in our registry, we put 2/3 of whatever the amount of BMAC we make, we put into the bone. And if you're doing foot and ankle stuff, I would say you put it into the calcaneus. If you're anchoring an Achilles down to the bone, you put it into the bone, you put some of it in the tendon and some of it around the tendon. And so that's the BMAC part of it. These things will absorb fluid, which has already been discussed in the webinar. So whether it's a patch or a suture, it'll absorb BMAC, PRP, and it serves as a scaffold. And so I think that's a great way to do it. I would use this for in the shoulder, side to side sutures. You add it to an anchor. If you're adding a patch, then it goes through your patch as well.
That's great. I have a special guest star I need to introduce. Joe, Joe Abood, where do you think this is going to be used and incorporated into your practice?
I mean, I think it's going to be seamlessly incorporated in my practice, just like the competitive product has been incorporated in my practice everywhere and anywhere, because if you can add more biology and less abrasion, saw a guy today with triceps repair that was done, and don't have this available in my facility yet. ZB guys, but
intent
knots are bothering his skin, kind of complaining about that a little bit. Lower profile, more absorption, more more orientation and less scarring with the collagen. Very important. Congrats to all the companies that are really pushing the biologic envelope, creating a competitive atmosphere. So it's really helping our patients at the end of the day.
Is Eric Black on here? Eric, are you around?
I'm here. How are you?
Eric, talk to me about your use of biologics. And
I agree 100% with Joe. I think
Oh,
You know,
don't
I use
always
it everywhere.
agree. Don't always agree 100%
I
with
love you, Joe. No, but in all seriousness, I use it everywhere and anywhere I can. I've been using it for subscap repairs and totals, distal biceps, common extensor repairs with push locks. And I agree, it's very seamlessly incorporated. It handles well, and it makes a ton of sense when you speak with some of these giants who are on this call from a biologic standpoint. Why not use it? The cost basis is not substantially more than some of the competitive products, and I think that makes it much easier and more facile than patches and other things. And I'd love to see it in anchors sooner rather than later. Can't wait.
Ira, do we have to finish up? 9 o'clock, witching hour?
Well, we can, we could keep on going a little bit more, but I think we've covered everything. This was phenomenal. Anand, you made my life easy tonight.
Well, that's my job. So, a lot of people want to get back to the World Series, even though the Yanks are leading, unfortunately. I want to thank the faculty. All of you are outstanding. Thanks to Zimmer Biomet for sponsoring. Ira, of course, the godfather of Joey. And it's a great format. Hope to join you again soon, and hope everyone has a good night. Safe night.